So the next section is the cardiac pathology, and the first condition in the cardiac pathology is the ischemic heart disease. Ischemic heart disease is a group of clinical syndromes caused by the myocardial ischemia, where the oxygen supply is unable to meet the myocardial oxygen demand. It is one of the leading causes of death worldwide, and are most commonly caused by the atherosclerosis of the coronary arteries, leading to the reduced coronary blood flow. And we will discuss the atherosclerosis in detail in the next chapters. The severity of the ischemic heart disease depends on the degree of the coronary artery narrowing, the duration of the ischemia, and the oxygen demand of the myocardium. The risk factor in this case is the hypertension, diabetes mellitus, smoking, hyperlipidemia, obesity, and the increasing age. Family history is also important in this case. Coronary artery narrowing usually become symptomatic when the stenosis exceeds nearly or more than 70% of the lumen. The next in the section is the angina. The first one is the stable angina. The chest pain occurs during exertion or the emotional stress, usually due to the fixed atherosclerotic narrowing of the coronary arteries more than 70% stenosis. Blood supply becomes insufficient due to the increased physical activity, and this represents reversible myocardial ischemia with no necrosis. Pain commonly radiates to the left arm, neck, or the jaw. The clinical feature in this problem is the chest tightness or the pressure lasting less than 20 minutes, and the shortness of breath, and sometimes patient present with the sweating. The ECG findings in this case is the ST segment depression due to the subendocardial ischemia, and this pain is reduced by the rest of the nitroglycerin. Troponin levels or the cardiac marker levels remain normal because myocardial cell death does not occur. The next is the unstable angina. The chest pain occurs at the rest or with a minimal exertion, usually caused by the rupture of an atherosclerotic plaque followed by the thrombosis and incomplete coronary artery occlusion. And this represents reversible ischemic injury without the necrosis. The ECG findings in this case of the ST segment depression may be present. High risk of progression to myocardial infarction in this case. The pain in this case may improve with the nitroglycerin but often recur. Considered part of the acute coronary syndrome, the unstable angina is considered as the part of the acute coronary syndrome. The next is the Prince-Metal angina or the variant angina. This is the episodic chest pain unrelated to the exertion caused by the coronary artery vasospasm, usually occur at the rest, often during early morning hours. The pathology in this case is the reversible myocardial ischemia without the necrosis, and the ECG finding in this case is the transient ST segment elevation due to the transmural ischemia. And the point to remember is that the ST segment elevation is just transient, not the permanent. The treatment in this case is the nitroglycerin and the calcium channel blockers. Coronary arteries may appear normal on angiography in this case. The next discussion is the myocardial infarction. The myocardial infarction is the necrosis of the cardiac myocytes due to the prolonged ischemia, most commonly due to the rupture of an atherosclerotic plaque over the superimposed thrombosis causing the complete coronary artery occlusion. Other important causes including the coronary artery vasospasm, embolism, vasculitis, and cocaine use. Clinical feature in this case is the severe crushing chest pain lasting more than 20 minutes. Pain radiates to left arm, shoulder, neck, or the jaw. And patient may present with sweating, dyspnea, nausea, anxiety may occur, and pain is not relieved by nitroglycerin. The commonly involved area in this case is in the myocardial infarction is the left ventricle is the most commonly affected. Right ventricle and atria are usually spared. The coronary artery involvement in this case is the left anterior descending or the LAD artery is the most common involved artery. So the LAD means the left anterior descending artery involvement will causes the infarction of the interior wall of the left ventricle and the interior interventricular septum. Second most common artery involved is the right coronary artery. It causes the infarction of the posterior wall, the posterior septum, and the papillary muscles. The third most common involved artery is the left circumflex artery. It causes the lateral wall infarction of the left ventricle. Now we will discuss one by one the morphological changes in the myocardial infarction. First we will talk about the time from infarction, then the gross changes, and then the macroscopic change in this case. So if the time is less than 4 hours, there will be no such gross changes and there will be no macroscopic changes. And if it is from 4 hours to 24 hours, means the first day of the myocardial infarction, there will be the gross changes of the direct discoloration, and there will be the coagulative necrosis as the macroscopic change in this case. And if it is from 1 to 3 days, there will be the grossly yellow pallor, and there will be the neutrophils on the macroscopic changes. And if it is from it is from the 4 to 7 days, means the 1 week, there will be the yellow pallor as a gross changes, and there will be the macrophages, means the signs and symptoms of the inflammation as the macroscopic changes. And if it is from 1 to 3 weeks, there will be the red border emerges as granulation tissue summated from edge of the infarct. So this is the gross changes. And on the macroscopic changes, there will be the granulation tissue with the plump fibroblasts, collagen, and the blood vessels. So the macroscopic changes in this case is super high yield to remember it from the exam point of view. So the next is, if it takes months, there will be the white scar. Or on the gross changes and on the macroscopic changes, there will be the fibrosis, because the granulation tissue with the plump fibroblasts, collagen, and the blood vessels, then it's convert into the fibrosis. So these are the morphological changes in the myocardial infarction. Now we will discuss the important complications of the myocardial infarction in the same table. So if it is less than 4 hours, we will just compare it to the time from the infarction as given in the table, that the first is the cardiogenic shock in the massive infarction and the congestive heart failure and the arrhythmias. But if it is from the 4 to 24 hours, the important complication in this case is the arrhythmias. And if it is from the 1 to 3 days, the important complication will be the fibrinous pericarditis and present as a chest pain with the friction rub. And the next complication is the rupture of the ventricular free wall leads to the cardiac tamponade. The free wall actually means that the wall of the heart that is in a contact with the pericardial space. So if it get rupture, it will cause the blood or the fluid in the pericardial space, which will lead to a compression of the heart. This will lead to the cardiac tamponade. The next is the interventricular septum rupture, which will leads to shunt or the papillary muscle rupture, which leads to the mitral insufficiency. The next is that if it takes months, so the main complication in this case is the aneurysms and the mural thrombus or the Rester's syndrome. So this was all about the complications of the myocardial infarction.